So, good afternoon. Good afternoon, respected sir, my colleagues and dear residents, and all those who have joined us on the YouTube channel. Welcome to the clinical grand round of to be presented by Division of Trauma Surgery and Critical Care. Myself, Dr. Sushma, professor in the Division of Trauma Surgery. We shall be presenting our experience of traumatic cardiac injury, our last 15 years journey. Since the inception of Trauma Center from November 2006, we have been managing and witnessing almost about 70,000 patients per year. And even during COVID, we have seen that we almost managed 45,000 patients per year in 2020 and 2021. Despite that, there was so much of lockdown, and we had managed these cases from a makeshift emergency. In the trauma center, apart from head trauma, which is being managed by neurosurgery, orthopedic trauma, which is being managed by the orthopedics department, rest all other injuries involving from face, chest, torso, abdomen, pelvis, and extremities are being managed by the trauma surgery specialty, supported by the Department of Plastic Surgery, ENT, eye, and pediatric surgery as and when required. So here we present our experience of cardiac injuries, and I shall be joined by my department colleagues, Dr. Junaid Alam, Dr. Dinesh Bagaria, Dr. Narendra Chaudhary, Dr. Abhinav Kumar, Dr. Pratyusha Priyadarshi. And to summarize and conclude our whole experience, it will be Dr. Biplab Mishra, Dr. Subodh Kumar, and Dr. Amit Gupta. So Dr. Junaid Alam, to start with our index case, and we shall be presenting in these headlines. So to begin with, Dr. Junaid.
Good afternoon, all. Let us start with the case scenario. A 19-year-old male was alleged history of assault at 7 p.m. was taken to nearby hospital after 1 hour of injury, and the initial management was done there. After 1 hour of arriving that hospital, the patient was referred to our hospital for further management. So at the time of arrival, the patient was having mechanism of assault by sharp object, and there was a penetrating wound over the chest at the sixth intercostal space, right paraesternal region. The patient pulse rate was 148 per minute, and the BP was 90 by 45 mm of Hg, and patient was unresponsive. So outside hospital, the patient received steroid and PRVC, and there was bilateral ICD in situ, and the output in the ICD was 1400 ml, which was from the right ICD, and that was clamped, and from the left ICD it was 200 ml, and they were hemorrhagic. So primary survey done. The airway was threatened. The patient was intubated, and the air entry of the right side was decreased. CCT was negative. The SpO2 was 96%. Pulse rate was 34 per minute, and there was bilateral ICD in situ. The patient was connected to the ventilator, and the right ICD was unclamped, and approximately 800 ml of fresh blood came. So in circulation part, the patient was having heart rate of 144 per minute and BP of less than 90, that is 85 by 45 mm of Hg. And there was a penetrating wound of 3 into 1 centimeter on the right paraesternal area at 6th intercostal space, and there was no external bleed. So 1 liter of crystalloid was given to this patient, but the heart rate and the BP remain constant, and that was less than 90. And patient GCS was E2 VTM5, and hypothermia was prevented in this patient. So this was the content of the ICD. So adjunct to the primary survey, EFAST was done, and pericardial window was negative in this patient. Hepatorenal, splenorenal, and pelvic window was negative, but the right pleural window was gross positive, and the left pleural window was also positive. Chest X-ray of the patient, this patient was done, which shows the right hemothorax with bilateral ICD in situ. The AVG done. The patient was having the pH of 7.17, bicarbonate of 12.2, the base excess of minus 14.9, and lactate 9.5. So, to summarize this case, a young male with history of penetrating assault chest, which was having grade 4 hemorrhagic shock, was having the right hemothorax, and this is characterized as non-responder. So, in non-responder cases, we usually used to start the damage control resuscitation, in which which includes the limited crystalloid infusion and major hemorrhagic protocol activated in this patient, and early blood products started. As the patient received within 3 hours of injury to our hospital, we gave tranexamic acid in this patient. But the main focus is early hemorrhage control, and for this, we have to stop the bleeding. So, for the stop phase of the bleeding, we have to shift the patient to OR, and the patient was shifted to OR approximately 3 hours after the injury. So, the possible injury depends on the site of the injury and the size of the weapons and the trajectory. And the possible injury in our mind was that the patient may have right intercostal artery bleed, the right internal mammary artery bleed, there may be some lung injury or cardiac injury or great vessel injury, uh, maybe some in the abdominal organ injury. So the patient came to our emergency department at 9:45 p.m. and we rushed this patient to OT at 10 p.m. The total door to knife time was 15 minutes. So in as we are thinking, the patient was having the massive hemothorax. So we did the emergency right anterolateral thoracotomy in this patient, and but we find that the patient was having the massive right hemothorax along with the hemopericardium, and there was a penetrating tract traversing through the pericardium. So we have to expose this area, and we converted it into the clamshell thoracotomy, where the pericardium dent was found, and that was 2 centimeter in size, and there was 3 perforation noted in the right atrium with active bleeding, and there was a laceration at the lower lobe of the left lung with air leak. So temporary hemostasis was achieved using this instrument, that is the Satansky clamp, and we repaired over this with 3-0-proline. And the lung laceration was also repaired, and the apical and the basal ICD was placed. The chest wall is closed in layers. So in ICU, the patient stayed in the ICU for 11 days, and the ICU course was nearly uneventful. The patient was shifted to ICU in intubated state with pulse rate of 124 per minute and BP of 100 by 60 mm per day with inotropic support of NORAD at 8 mics per hour. And in ABG, the patient was having 7.34 pH with minus 5.4 base excess, and lactate was 4.7. And so the TEG based blood transfusion was given in this patient, and that is the 8:8:8 blood transfused. After that, the patient on the day 1, the patient pulse rate decreases to 110, and the BP started rising, and the NORAD support decreases from 8 to 2, and the ABG was started normalizing. At PUD2, the patient was extubated and kept on the mask, and the echo was done in this patient, bedside echo, which shows the mild tear. And on the PO2 11, the patient bilateral apical ICD was removed, and the patient was shifted in ward. In ward, on day 12, we assessed that the patient was having the bilateral basal atelectasis, for which we have done the intensive chest physiotherapy in our spirometer. Patient got improved. On day 14, left basal ICD was removed, and on day 19, the patient was discharged from the hospital. The total ICU stay was 11 days, and the length of hospital was 19 days. So at 6 weeks, we follow up the patient, and the patient is doing well, and there is no regional wall motion abnormalities, and the ejection fraction is more than 60%. Now I invite Dr. Dinesh to discuss about the ED management.
Good evening to all. Transition of care from casualty to a dedicated ED department, where an evidence-based protocolized approach is used for the management of trauma patients, has made a significant difference in the outcome of patients. One such protocol, which is used worldwide, is ATLS protocol, that is Advanced Trauma Life Support. In our ED at AIIMS New Delhi also, we follow this protocol in letter and spirit. The moment patient arrives in the ED, he will be triaged into one of these categories, that is the red, yellow, and green, taking into account his physiological status, the anatomical injuries inflicted, and the mechanism of injury. The category in which the patient is triaged will denote the urgency and level of the care patient needed. So patient will undergo initial assessment, that is the primary survey. Primary survey is nothing but clinical assessment and simultaneous intervention if needed to correct any physiological derangement found during the primary survey in the ABCDE. A denotes airway and cervical spine control. B denotes the breathing and ventilation. C denotes circulation and hemorrhage control if needed. D is for checking the neurological status. E about taking environmental control and the exposure. Along with the clinical assessment, there are few additional vital monitoring, output measurement, and few imaging which we use for support our clinical assessment. And the imaging primarily used in primary survey are three, that are chest X-ray, pelvic X-ray, and point of care ultrasound used as E-fast one. Our objective of this initial assessment is to find the physiological derangement cause of injuries which are immediate life-threatening injuries might kill the patient within the span of seconds or minutes. The one modality which has changed difference in the management of the trauma patients and hemodynamically unstable patients per se is the point of care investigation use of ultrasound as extended focus assessment with sonography in trauma. This is a point of care investigation, as I said. So the radiology is supposed to come at the patient rather than shifting the patient to the. And in this investigation, we just try to find out if there is any presence of free fluid, pericardial, peritoneal, or pleural peritoneal. FAST is not used at this moment of time to diagnose any specific injury. And if any fluid found within any of these category will be considered blood unless proven otherwise. And in hemodynamically unstable patient, that cavity will be considered as culprit and further course of action will be decided accordingly. So in a hemodynamically unstable patient where we found that in the primary survey he is not responder, along with our adjunct of fast and intervention, this patient will undergo the damage control resuscitation. What is damage control resuscitation? Damage control resuscitation is a process of care which involve multiple intervention done at various point of time at various places, ultimately to achieve the object of correction of the physiological derangement. Two intervention we do in the ED are the balance resuscitation, correction of coagulopathy, initiation of major hemorrhage protocol, and use of anticoagulation. These interventions will start in the ED, but they will be carried out throughout the process of the care in OT and ICU as and when required, depend upon the response and injury of the patient. Balanced resuscitation, we have graduated from the era where development of pulmonary edema used to be considered an indirect sign of adequate fluid resuscitation to the present day where we restrict the IV fluid because we want to get a good trade-off between the organ perfusion and reducing the risk of rebleeding. Besides that, we also start early use of blood product. The major hemorrhage protocol. Major hemorrhage protocol is the protocolized approach of blood product transfusion that we start blood transfusion early during the course and to achieve final predefined ratio of blood products of nearly 1:1 of packed RBC, FFP, and platelets. Nowadays, we have enough evidence available to support the use of tranexamic acid In trauma management, it has been shown to reduce the overall as well as the hemorrhage related mortality if given within the span of 3 hours. So this is the story about the patient who is hemodynamically unstable. But what about the stable patients? Unstable patients, we have done the primary survey with the adjunct. Now these patients will undergo re-evaluation, and then they will undergo the detailed secondary survey along with the use of specific investigation to find out any anatomical injuries further. A few words about the pericardiocentesis. What is the pericardiocentesis? Pericardiocentesis is needle aspiration followed by catheter drainage of the pericardium cavity, the blood containing it, in a patient who are having features of cardiac tamponade. But it is a temporizing measure and it is not a definitive treatment of cardiac tamponades. Ultimately, we have to push the patient to the OR. And that's why in initially few patients we use this. Now we are investing our energy and resources to push the patient in the OR as soon as possible rather than doing the intervention in the ED. But still, they are temporizing measure and in resource constrained setting, their immediate availability of OT is not possible, as well as the expert surgeon is not available, or we have to transfer out the patient to higher center. Pericardio center is a life-saving strategy. Further operative management, I trust Dr.
A very good evening. For next couple of minutes, I will take you through the intricacies of operative management, right from starting from the transfer of the patients from ER to OR, then placing the patient, positioning the patient, then choosing the operative incision based on multiple factors, then opening the chest cavity, then finding out the injuries and how to take the hemostatic measures, temporary as well as definitive, and finally how we should close the cavity. So for next couple of minutes, we will discuss all these things. So since we all know that trauma management is a team approach, multidisciplinary, multi-modal approach is at hand to have a successful outcome in a trauma patient. So shifting from ER to OR is not different from a team approach. Here a very well coordinated team approach is required in a timely manner. Time is of the essence here. The patient is actively bleeding, he is in hypotension, he is categorized into the non-responder category, and the thing that he is at the least is the time. So we have to save the time, and to save the time, we must have the coordinated approach. During the coordinated approach, there should be the pre-transfer for information to the operating room. So the operating room information should include stop the air conditioning, since we all know the patient is losing the blood, that blood is losing at 37 degrees Celsius. So patient has a high chances of he will go in the hypothermia, as well as we already have started the MHP or we have already infused a lot of crystalloids. So patients has a high chances that he will go in the hypothermia, and once the hypothermia sets in, the lethal triad of trauma sets in. So for every possible purpose, we have to avoid that thing. Second is start warmers for the same purpose of avoiding hypothermia. Then start the timer. You must start the timer so that it will keep on reminding you that how much time has been elapsed while shifting the patient. Then prepare the draping trolley so that once the patient reach in the operation theater, your time will be saved. Your time will not be wasted in such a vague things. Then prepare the thoracotomy set, including the external sew, vascular set, and sometimes laparotomy set may be required because patient may have the multiple compartment injury. Then the anesthetic information. This is also a very crucial information that you should share while shifting the patient to the emergency room. You should share that at what estimated time the patient will be wheeled into the operation room, so that anesthetist has already prepared himself for the anesthesia and he has already achieved all of the preparations whatever he anticipated at that time. Then what are the suspected injuries you are suspecting in that particular patient? That information is important to you as a surgeon as well as to the anesthetist for managing that particular patient. Then we should also discuss the planned incisions and approach, which cavity we are going to approach, which incision we are going to do, which position we are placing in the patient. So all these potential information should be shared beforehand to the anesthetist before shifting the patient to OR. Then blood bank is not the least and not the last important thing. This is also equally important that you should give the information to the blood bank that now we are shifting the patient from ER to OR. So the next batch of the blood that they are releasing should reach to the OR in the time rather than to the previous position. As well as you should also communicate with the anticipated need. So how much blood you will be requiring, in which proportion you are requiring, and at what quantity you will be requiring. So with this coordinated approach and with coordination between different modalities, different disciplinaries, we will shift the patient from ER to OR with keeping in mind the time. Then once the patient reach inside the operation theater, the induction as well as the operative site preparation go side by side. We don't have the luxury that the first the patient go under the induction and then we will place the incisions. So on the one side, the anesthetist is putting the all the machinery for the induction. At the same time, we are preparing for the coming incision. The operating field sterility is not the luxury for us. Sometimes we have to operate the patient under suboptimal conditions also. We can't rub him or we can't scrub him multiple times because we don't have the time. We are losing the time. So sometimes in suboptimal conditions, we place the incision. Then ongoing communication with anesthetic team is critical. There will be multiple points during the operation where you need to communicate with the anesthetist. Sometimes when you reach in the thoracic cavity, you ask the anesthetist to have a short brief of apnea so that you will not inadvertently damage the thoracic vessels or lungs. At the same time, sometimes you are suddenly decompressing the cavity. So beforehand information to anesthetist should be there that we are decompressing the cavity, patient have the chances of going into the hypotension. So all these things should be communicated during the operation also. Then comes to the patient positioning. Patient positioning governs by multiple factors. The first and foremost is the hemodynamic status. If the hemodynamic status is not stable, then you left with only the supine position because rest other position requires time and you don't have the time. Other factors that can govern the position of the patient is location of penetrating injury. If the location is something that is not visible in the supine position, then you have to change the position. Anticipated intrathoracic injuries, what type of injuries you are suspecting and what approach you can take for assessing those injuries. And then the presence of impaled object. Sometimes the patient carried here with the impaled object in situ. In those conditions, sometimes there is a limitation that we can't place the patient into the supine position. Then according to that, the situation of that impaled object, we will tailor made the position of the patient. Then after that, the positioning in trauma patients usually done in the supine position when the patient is hemodynamically unstable. Then selection of thoracic incisions. Then selection of thoracic incisions again depends on major three eyes. These three eyes are the location of impact on the patient, the suspected organ injury, and the presence of impaled object. So based on these three eyes, we will choose the incision, whether it should be the anterolateral, whether it should be the clamshell, whether it should be the posterolateral. Depending on these three eyes, we will choose the thoracic incisions. Other than these three eyes, two more important factors that governs the selection of incision is urgency of the procedure, how much urgently you have to do the procedure, how much urgently you have to approach the thoracic cavity, as well as anticipated need for aortic cross clamping. So we all know that aortic cross clamping is usually done in the descending thoracic aorta. So all the incisions will not take you there at the thoracic aorta for the cross clamping. Only few incisions can take you there. So depending on the anticipated need of cross clamping, we will choose the incisions, whether we should give anterolateral or clamshell or posterolateral. Then we will discuss one by one different type of incisions approaches to the thoracic cavity. The first and foremost approach is median sternotomy. Here we will go in the midline and we will split the sternum into the two equal halves. The pros of this particular sternotomy is that it is preferred by most of the cardiac surgeons, maybe because of the training and the experience. The second one is this approach will provide good exposure to the heart, to the anterior mediastinal vessels, as well as trachea, specifically the middle and distal third. So these, if you are suspecting these structures, this approach may be a prudent approach. Then fewer pulmonary complications are also reported in the literature associated with median sternotomy. However, some cons are also there, some drawbacks are also there associated with median sternotomy. They are inadequate posterior mediastinal exposure. So we all know that if there is a posterior mediastinal exposure is inadequate, the aortic cross clamping cannot be possible in particular. So when you are anticipating that your patient may go in hypotension or you need a aortic cross clamping, this approach may not be a prudent one for your patient. Then, as I already told you, it will not be useful for resuscitative purpose because aortic cross clamping is a part of resuscitation. Then limited exposure of bilateral pleural cavity. It will give very good exposure of the mediastinum, but bilateral pleural cavities approach is limited in this particular incision. Let's see how it's seen. So we will give the midline incision. We will split the skin. Then we will core the midline of the sternum with the cautery. We will divide the interclavicular ligament so that the vessels that are just lying beneath the sternum can be separated, and inadvertent injuries to the innominate can be avoided. And after that, with the use of sternal saw, we can give a midline incision. The coring in the midline has the purpose so that your sternal saw will go in the midline only. It will not deviate in other paths. So it will guide you once you core the sternum. It will guide you how to this sternal saw that it should remain in the midline. It will not deflect on the either sides. Once you open it out, you will be directly landed up in the anterior mediastinum where the heart, distal trachea are very easily visible, as well as the great vessels can be seen very easily. So you are suspecting such type of injuries in these particular organs, you can approach this median sternotomy. After the repair, the closure is usually done with the interrupted stainless steel wire and followed by subcuticular closure of the skin. Then another approach is anterolateral thoracotomy. Anterolateral thoracotomy again has few pros as well as the cons. The pros are that this is the preferred for the emergency resuscitative thoracotomy. So usually the left-sided one. Here, this is the approach where you can approach the posterior mediastinum as well. You can approach the ipsilateral thoracic cavity as well as you can approach the heart. So this one approach is that where you can actually find out all the bleeding organs, and as well as this will be helpful in your resuscitative thoracotomy also. Then few cons are that contralateral chest cavity remains inaccessible. To achieve the contralateral chest cavity, you have to cut the sternum and you have to cross to the contralateral side. That will be the clamshell incision. We will discuss in the coming slides. There will be a poor exposure of superior mediastinum. So great vessels cannot be approached through this incision, and it needs division of major muscles, pectoralis major, pectoralis minor, as well as serratus anterior. This is the brief picture of how you will approach from extending from the mid-axillary line to the peristernal region in the fifth intercostal space. We will give the incision. This is the approach where you can see the left-sided pleural cavity with lungs protruding, the heart as well as the diaphragm. This is the approach where you can see these things. Then posterolateral thoracotomy. These are useful for elective cases but not useful in the emergency setting. So we don't use this particular approach in emergency cases. Then bilateral clamshell incision. This is the workhorse for trauma team. We almost always use such incisions for all the non-responder patients or suspected cardiac injury patients. This is the preferred incision. It's a quick that gives good exposure to the heart, mediastinum, as well as bilateral pleural cavities. Aortic cross clamping is possible in this, as well as few of the hemostatic procedures like hilar twist or can also be done through this approach. It's a time-sparing approach. Cons are it's long incisions extending from bilateral anterior axillary line, dividing the sternum also, needs major muscle divisions, as well as great vessel access is slightly difficult in this. This is the position. Patient remains supinely positioned with the bilateral arms abducted at 90°, and this is the incision site extending from anterior axillary line, cutting the sternum and going opposite to the anterior axillary line usually in the fifth intercostal space or inframammary fold. This is the approach. You can see the cut ends of sternum, and here you can nicely see all of the heart as well as bilateral lungs, pleural cavities can easily approach through this. Even the posterior mediastinum as well as the diaphragm can be approached through this incision. So it will be useful for resuscitative purpose as well. Once you reach inside the thoracic cavity, the next approach is to explore the heart. For exploring the heart, you need to divide the pericardium in longitudinal position, just anterior and parallel to the left phrenic nerve. that goes just left side to the heart. You can see here the reflected part of the pericardium that is splitted longitudinally. Then after splitting the pericardium, you will drain out all of the blood, you will remove the clot, and you will see on the surface of the heart where it is bleeding, where is the rent. Once you identify the rent, there are few temporary measures through which you can achieve the hemostasis. First and foremost, that is most commonly used is the finger occlusion or digital pressure, applicable more in the ventricular rents. Then occlusion with partially occluding vascular clamps, named with the great surgeon Satinsky. So this is more feasible in right auricular or right atrial rents, where you can clamp it out and then you will do the suturing. Then few more techniques are there that we are not usually using them, but they are described in the literature. For the sake of discussion, I am putting them. One of them is putting the Foley's catheter inside the rent and inflating it and pulling it out. Another one is putting the skin stapler. This is the desperate measure when the patient is in extremis. We can use the skin staplers also. It's only a temporary measure. This is not a permanent measure. You always have to follow it by the cardiography. So once we achieve the temporary hemostasis, we will go for the definitive hemostasis in the form of cardiography. The suture usually used is 3O non-absorbable polypropylene suture with tapered double needle rounded body, and figure of 8 or horizontal mattress configuration is used for the hemostasis, and flagellated versus no flagellated sutures. Usually the non-flagellated sutures are used until unless there is the cutout of the sutures or when there is the old patients with the fragile heart tissue is there, because putting the flagellate will leads more time and you will waste more time. So it is not recommended that you should use the flagellate. Whenever there is a cutout or when is a fragile heart, then only in selected cases we use the flagellated sutures. Then one special scenario when the rent is very near to the major coronary vessels. So to avoid inadvertent occlusion of the vessels or to trap inside the this suture, we will take the sutures just beneath the coronary vessel like this. So this is the rent, this is the major coronary vessel, and we will take the suture just beneath the coronary vessel. Here you can take, we are making the horizontal mattress and it will be closed and the coronary vessel remains the patent. With this, I conclude the surgical part here, and I will take you to our experience.
Thank you, Dr. Narendra. So now I will share our experience of managing cardiac injury patients at our trauma center. All patients who were managed during last 15 years, uh, admitted during July 2008 to February 2022 were included in our study. So during these 15 years, around 33,000 major trauma patients were admitted, out of which around 6,000 patients were major thoracic injury patient. That accounts for around 400 major thoracic injury patient per year. And of these patients, 59 patients had cardiac injury, which is approximately 1% of all thoracic injury and 0.2% of all major trauma admissions. So on an average, we see 4 to 5 patients per year. Most of the patients are younger, and as you can see, around 1/3 of patients were in the 21 to 30 age group. Median age was 28 years. 90% of our patients were male, very few were female. And most common mode of injury was penetrating injury. Around 2/3 patients sustained penetrating injury, while 1/3 had blunt injury. In our initial period, the blunt injury was more predominant. However, the trend has recently reversed. We get more penetrating injury compared to blunt injury. Among penetrating injury, most of them were low velocity assault by stab. Firearm injury were only 6. And in blunt injury, road traffic injury were most common mode of injury, followed by fall. Our injury to ED presentation time for primary cases was around 1.5 hours. However, for referred cases, it was around 4.5 hours. and average presentation time was around 3 hours. Almost 3/4 of our patient had shock at the time of presentation, and as you can see, 38 patient had systolic blood pressure less than 90. They were in grade 4 shock, and 42 patient had tachycardia at the time of presentation. 51 patients were fast positive in the pericardial window. Only 4 patients were fast negative. So fast has a very high sensitivity for detecting cardiac injury. 4 patients were presented to ED in extremis, and they underwent ED thoracotomy and were shifted to OT. So they didn't give us time to perform even fast. Around 50% of our patient had pericardial tamponade at the time of presentation, and pericardiocentesis was attempted in 7 patients. As Dr. Dinesh has already mentioned that we have abandoned doing pericardiocentesis because it is time consuming and it delays the transfer of patient to the OR, and we have our OR is geared up for receiving non-responder patient immediately. So our door to knife time in cardiac injury patients were 19 minutes, and we have a protocol that all non-responders should be shifted to OR within 30 minutes. As you can see, most of our patient are were shifted to OR within 30 minutes. And our preferred surgical approach was clamshell thoracotomy, as already mentioned by Dr. Narendra, because it provides quick and good access to both thoracic cavity and for all cardiac chambers and great vessels. And in few patients, we did anterolateral thoracotomy, and only in 2 patients, the posterolateral thoracotomy was extended to perform the repair of cardiac injury. These are the details of cardiac injury operated intraoperatively. As you can see, in blunt injury, atrium and ventricle are almost equally involved. And however, in penetrating injury, there was a predominance of ventricular injury than atrium injury. You all can see right side involvement is more in the blunt injury, and in penetrating both are almost equally involved. However, the left ventricle was the most predominant, followed by right ventricle injury. A significant portion of our patient had more than one chamber injury in 5 patients, and also in 7 patients we had combined cardiac plus vascular injury. Only 3 patients had hemopericardium with no pericardial injury. Post-op complication, we encountered one patient with rebleeding, which was re-explored, and one patient had post-op dysrhythmia. We had no patient who developed myocardial infarction in post-op period, and we had no valvular abnormality. One patient had a stroke in post-operative period, and one patient had ARDS. Among all these cardiac injury patients, only 26 patients were isolated cardiac injury. Almost more than 50% had some form of associated injury, and most common was lung injury, followed by abdominal solid organ injury. So we compared 2 group of patient who did not survive and patient who survived. We compared all the variables which are significant for survival, and we found that ISS and cardiac arrest were 2 variables which were found to be significant. In patients with mortality group, the ISS was comparatively high, and also the incidence of cardiac arrest was more in the patients who did not survive. So patients who are having cardiac arrest in perioperative period have less chances of survival, as you can see in this slide also. Only 20% of the patient who had cardiac arrest in ED survived, and around 31% of patients having intra-op cardiac arrest survived, and in patient having post of cardiac arrest, none had survived. However, it is important to note that even after having cardiac arrest, the patient had survived. So there is we have we have to make an effort to salvage this patient. This is our overall outcome. Overall survival was 61% and overall mortality is 39%, which is comparable to our literature. And in both penetrating and blunt group, the survival was similar, around 60%, and mortality was 40%. One patient in our penetrating group was managed non-operatively. However, this patient unfortunately did not survive. It was a missed injury. And in three patients were managed non-operatively in blunt injury, and all of them survived. So now the follow-up part will be discussed by
Patient discharged to home in stable condition. The important landmark in the journey of the patient. As surgeon, we take immense pride while achieving this landmark. So equally important is to have a good follow-up place so that we can find out if they have any immediate issues to address them and how they are performing in the long term, how they are contributing in the society, which is the ultimate goal. So with objective of this follow protocol, we also followed our patients who survived, and we could able to achieve 55% follow-up of our survived patients, expanding the span of from 6 months to 14 years. These followed up patients were followed up in physical OPD as well as through the teleconsultation. And during follow-up, we found that all the patients whom we could contact, they have resumed their daily activities. 20% patients reported occasional pain at the surgical site, and none of the patient had any acute episode related to cardiopulmonary complications require immediate attention. Our discharge and follow protocol is we do ECG and 2D echo on post of day 1 or 2, depend upon the patient, and just before the discharge. After that, patient will follow up in the after first week to examine the local site and for suture removal. After that, patient will follow up of first month. After that, as and when required, patient will follow up if he has or she has any complaint. We generally don't evaluate all the patients, only the patients who are having any symptom, they are being followed up and require cardiac evaluation. Now it is quite intuitive that the patient who have suffered such a major injury might develop long-term complications. They should be followed up more frequently and more for long period. To find out this, we did the literature search, and this is the one important multi-centric study, including the one center is the shock trauma center, which is epitome of the trauma care. And in 26% of their survival patients, where they followed up protocol of ECG and 2D echo post-operatively and 1 month, they followed up these patients for 1 year, and they could find that none of the patients develop any complication in the only the 19 patients who had some sort of abnormality, they were detected only during the in-hospital admission, which even didn't require any surgical correction. Their conclusion was that the all abnormality, they are being detected during the initial post-operative echogram, and even there is no added any benefit of the study which is being repeated at the one. Same conclusion we were able to find from other studies, which is done by the Jones et al. And from the Hector et al. Give the more depth review of the literature, I request Abhinav to.
Thank you, Dinesh. Just to begin with, in science, we always talk about evolution, and evolution is a continual process. And it's always better to look into the past, which will help you to introspect and to innovate in future what you have to do about. So this is what the cardiac surgery, the journey began. And the two paradigm was, the first was it was started with the tension that the heart is inviolable to any form of treatment, and this is continued till 2,400 years. Then Harry Shammer said the heart was only 2 to 3 centimeters in a direct line, but it took surgeon 2,400 years to travel to it. And this was the year that was in the era of late 19th century when Sir Ludwig Rehan did the first cardiography, and the paradigm was shifted from the no intervention to a intervention means emergency cardiography. And the second one, this came at just what you can say 100 years down the line, was the trauma care management system. What we have already talked about, the ATLS system by the American College of Surgeons, given by James Steiner, and it's changed the paradigm how you sit. And what they emphasize, two things: the systemic approach, which we have already discussed, and second was the timely intervention, timed interventions of any either surgical or medical intervention in an acutely injured patient have an impact. They have an impact. What? They improve the overall outcome of these patients. And basis of this was the damage control surgery, which was already discussed to you earlier. Then you move forward that in in the recent publication by Sir David Feliciano, Sir Mattox and Moon, it talked about what is so important in the cardiac injury. As a clinician, you should be there, but this is a rare and timely intervention is an essence. And you should be tailored to your institution, what the resources you have, what the capabilities you have. That's what is important. Question is always asked to the medical fraternity, surgical fraternity, who is going to do this? Who is going to intervene this? The answer may be the trauma surgeon, acute surgeon, general surgeon, or others. I'll come to you. And it has been suggested any surgeon with the capability of more than one cardiothoracic surgery, they are capable to deal with the acute emergency, cardiac emergency surgeries. And what they advocated, that in-house, they have advocated that in-house, all surgeons who are there in the trauma surgery must know the technique of cardiothoracic surgeries, emergency surgeries. So it's now, when we reflected our study with compare with the study which was tried by Charles, and this was a trauma-based registry from the Oklahoma State, that they had done a 10-year study of their trauma outcomes in the cardiac injury patients. What they found out was their incidence rate was 0.4 and our was 0.2. And throughout this period, they had 426 patients in 10 years, while in our study, it was only 59. But the incidence rate, if you just see, is less. And with the trend, what we have that the penetrating injuries, they have more than the blunt cardiac injuries. And while in the air, it was the blunt cardiac injuries was the predominant one, coming out to be more than 62%. So average case rate in our study was 5 to 6%. So you should understand this is a rare. And in there was a 4 to 45 cases per year. As we know in trauma, the T stands for time. And here the time is critical. This paper, which was by Kamali et al., we talked about what are the factors which influence the outcome of patients with a pericardial cutting. They studied 4 parameters. They studied into the surgical experience of a surgeon. It should be more than one. Second was the time to OR, what we are talking about, door to knife time. It was 15 minutes. Second, with the presence of cardiac tamponade, we talked about in our study with the cardiac tamponade and this. And then what they come out to be, there are 2 things: the surgical experience of more than one case and your OT time from ED to the OR less than 15 minutes improves the survival. And sorry. And in our study, when we talk of trauma, we talk of 2 times: the pre-hospital time and the in-hospital time. Here, what we are talking about in our study, the mean arrival time from the injury to the ED is 165 minutes, while in the other studies, this was done by the Restero. They had analyzed 240 cases of penetrating cardiac injuries, which was published in European World Journal of Emergency Surgery in 2017. They said that they have that average time of 60 minutes. This highlights our limitations of the pre-hospital care, because this takes no time. Because this, as it may also be, they die on the scene or during the transport. So the second one is the mean time to the OT. From ED to an OT, in our study, for all 59 cases, it was nearly 90%, and which was comparable with the previous study when they talked about less than 15. This study, they had an OT time to it was the 15 minutes. When we come out to the mechanism of injury for the penetratory cardiac injury, this was evaluated with the compared with the Morse and Mina study, which they have compiled their study with the 36 experience in a level 1 trauma center in USA, and they said that in European country, the Western world, what is the most common mechanism is the gunshot injuries. They have 40%, while in our study it was less than, it was nearly 16%, less than 20. In blunt cardiac injury patients, the majority of the mechanism remains the same. The RTI was the predominant, followed by the free fall height. Coming to the location of the cardiac injury, when we compared this, the location of injury within the penetrating cardiac injuries, 38 patients underwent surgeries. Out of the 39, 31, one was a non-operative management. And what we see is the majority of them is of the right-sided, right ventricle and the right atrium. Currently is 60%. And this was in a way which was compared with the other study where they had the right-sided chamber involvement was more frequent. What was unique to our that we had some 3% of cases which had a pericardial injuries. Coming to the blunt cardiac injury patients, the more or less these were compared with those who had got operated. In our case, the operated was 18, and in this case study, which was done by Gao and Dow, which they have taken into account all 43 cases, those who have been operated, and there also the most common site was the right-sided ventricle and the atrium was the more common involvement. Physiological status. We all talk about physiological status at the time of arrival in the patients because this is what we times your management. And we talked about, so in our study, 27% were only stable and majority, what is it? The majority of the 73% of patients were in an hemodynamically patient, unstable. While in this study, which was done by Izaro, who compared the 240 cases, they had an unstable patient which was nearly 50%. And patients, those who have been cardiac tamponade, in our study it was found to be nearly 46%, and in there it was 67%. When you talk about move forward, when you talk of cardiac tamponade, if the question always comes to your mind, is it detrimental? Is it detrimental? Then this study saw when we compared our statistics with an with a 17 experience from an urban trauma center in Japan by Tanka et al., they found out that our study also had the mortality rate in the patients with cardiac was 37% only. This was compared, but and they were more in patients with blunt cardiac injury patients. And what about cardiopulmonary pressure? This is always a contention, but as a minor, for an acute hemorrhage control in cardiac injuries, you don't require NCPB. They are mostly done on the beating heart. And but they have a role. And so once you have done a hemostasis control, then what are those specific injuries that where you will require is the coronary artery injuries. These are more proximal than the diagonal. The valvular injury, either you got to know when you are done the intraoperatively or you have an echo and you find out that you have a valve repair. And in an elective settings when you can remove a foreign body impacting in the heart chamber. And in our study, we have all the emergency cardiac surgeries has been done without cardiopulmonary bypass. Moving forward, again, the surgical approach, everybody talks about what to do. Anterolateral thoracic clamshell or BDN sternotomy. The study by Dubois et al., this was from the AST IOTA group, they said that in an unstable patient, as a demographic we are talking, the clamshell thoracotomy facilitates life-saving procedure without increased systemic or thoracic complications. It is adequate. It's adequate in the sense of exposure and for surgical interventions. And in our experiences, as you have seen, 90% of incisions were all clamshell thoracotomy. So the outcome of, you must know, the outcome of traumatic injury, and these are the factors which are governed, and there's a mechanism of injury, as we all said, blunt have they have fared badly. The hemodynamic stability, the presence of cardiac tamponade, which are already talked about, the door to night time, you keep it limited to the achieve it with the 15. Single chamber injury, they have good outcome. Right sided, they have good outcome, and isolated injury fare well.
Thank you very much, Dr. Abhinav. So we published our initial experience in 2015, and the journey continues after that. And what we learned over the 15 years from not from patients with the cardiac injury, but from taking care of these trauma patients across board, that it affects mainly the younger population. And it has been proved again in the setting of the traumatic cardiac injury. In this study, the median age was 28 years. It affects the third and fourth decade of life. Not leave any stone unturned to save a life. Remember this, because he may be the only bread earner for his family. Every effort, especially for the resident, we should try hard to save a life. The traumatic cardiac injury is a rarity. In our series, it was 0.2% if we take into account all the admissions under trauma center. So the total admission in the trauma center across all specialties, orthopedics, neurosurgery, trauma surgery, is much more than 32,000. But the 32,000 admissions under the trauma surgery, if we consider, is 0.2%, and it is 1% if we take into account the major thoracic trauma patients. The favorable outcome depends upon the high index of suspicion based on the mechanism of injury. If you happen to see a patient who has sustained a penetrating injury in the parasternal region, in the cardiac, the cardiac box, there is a high chances that he is having a cardiac injury or a great vessel injury. So you should make a prompt diagnosis based on your high index of clinical suspicion. Patient might be having features of shock. FAST is a very handy tool, and every doctor working in the ED must know how to do FAST. With due respect to all the radiologists, everything, you don't need a dedicated radiology person to do the FAST. Every doctor who is manning the emergency should know how to do a FAST. Immediate surgical repair without wasting much time for hemorrhage control, and the most importantly, it requires a teamwork. This index case, which we discussed in the beginning by Dr. Junaid, he was a referred case, but uninformed referral. It was an uninformed referral. Do not explore if you do not have a dedicated blood bank. ICU backup, experienced anesthetist can intubate this patient without no time. Trained trauma surgeons or a thoracic surgeon who has enough experience in opening the chest. It's better to transfer this patient to an appropriate facility, but with the proper communication. And at times, you have to put in a pericardial catheter as a temporizing measure. And of course, a chest tube if required. And do not clamp the chest tube after putting it. Another take-home message.
Successful management of trauma patient demand teamwork, and we take pride in acknowledging this fact that ours is a great team. We'd like to take this opportunity to express our heartfelt gratitude to them and acknowledge their roles, without which this journey of 15 years wouldn't have been possible for us. For obvious reason, we are thankful to our patients. Our core team doesn't only consist of trauma surgeon, but it consists of other specialties like emergency medicine. We are thankful to Dr. Sanjeev Puri for that, who is the leader of that emergency team. Radio diagnosis team, led by Dr. Shiva and Dr. Atin. We are thankful to them. Lab medicine, Dr. Purva Mathur. Blood bank, Dr. Arul Selvi. We are also thankful to nursing staff, physiotherapists, and our technicians. Last but not the least, we are also thankful to our residents, who are the real heroes and the workhorse of our core team. I would also like to thank the Department of CTVS, especially Dr. Shiv Chaudhary and Dr. Devaguru, for their ever-present help.
Thank you very much, Dr. Biplav. I think I'll just close by saying that today probably there was a poetic justice to this topic we were presenting as CGR, because in the morning, as we had discussed, we had a case of cardiac injury, or at least an injury which was affecting the cardiac box, and Dr. Pratyusha, Dr. Junaid, Dr. Abhinav were all there, all our residents were there, and we could probably manage that case. Although
it was not a classical cardiac injury, but it was a cardiac tamponade, pericardial tamponade, which happened. And within, I think, 20 minutes, the case was taken to the OR, and the aorta, the base of aorta from where it arises, from the left ventricle, was actually injured. I throw this open to discussion, and also I would like, first of all, our chief, Professor Malhotra, to come and give us some words of inspiration, and after that, Professor Chumba.
Thank you, Amit. We have run out of time, but I think it's very important that we highlight the messages which have been given. The matters of the heart are very delicate and they need urgent attention. The time is of essence, as you have been told. No time to be lost in imaging. The importance of fast has been told. And I was really proud to see that there would be times when they were opened in 2 minutes. The experience is limited at most places because it is a rare injury, and I was seeing that you are qualified to treat a cardiac injury, you need experience of one treatment. If you have treated one patient of a cardiac injury, you are qualified to treat a cardiac injury, and that's the kind of rarity. So I think our residents and trainees are very lucky to be working in the trauma center, and also that we are the people who have to lead the way. I mean, this is the Apex Trauma Center, and we have seen so many cases, and we can compare our series with the best in the world with comparable results. The results for cardiac tamponade, comparing best with those in Japan, which is supposed to be one of the best countries. And from the end of administration, although I'm not a trauma surgeon, but then we are setting up a hybrid OT, which will ideally be suited for patients like this, so that in Japan, we saw that if you had a patient like that, they would open it right in the casualty. We would do it in a desperate situation because our sterility, crowd, people around them, they have a patient like that, there'll be nobody around. So they can just open it anywhere. But we'll have a hybrid theater, right in the red area, so that these patients do not lose any time. They don't even have to be shifted to the main operation theater. And let's hope that we'll have even more facilities to quickly stabilize them and save every life, because anybody, even with an injured heart, if he comes with the heart beating to the ED, we will make every effort to make sure that the heart keeps beating. Thank you very much for your attention.
Thank you, sir, and very rightly said, sir. And we should thank all of us should thank you for the initiation of the hybrid OT project. I'm sure it will be there very soon, and many more lives with great vessel injuries, especially those who are bleeding to death, can be tackled there. Professor Chumbar, head of the Department of Surgical Discipline, sir, comments or suggestions.
That I have, I hope you will that you have mostly isolated cardiac pain. Yeah, I'm missing the additional injuries in these patients. That's what I would like to know. These patients had only isolated cardiac injuries, and you did not include other patients who had other injuries.
Only 26 patients had isolated cardiac injury, and they were mostly, sir, penetrating, like a stab in the parasternal. Blunt injury patient had, sir, one of them around 19 had lung injury, and then they had solid organ injury also. Patient had traumatic brain injury, then 13 had lung injury, and then diaphragm in solid organ injury 9, and hollow viscous injury 7 patients. Long bone fracture, soft tissue and other had. These are number of injuries, sir, combined. One patient had more than 2 reasons involved, so they had polytrauma.
Question?